So we've got to talk about a really shocking statistic right now, because the data show that Black women are 3 to 4 times as likely to die from pregnancy causes as white women are. And that includes Black women who have a high level of education. In fact, the US is only one of 13 countries in the world where the rate of maternal mortality is now worse than it was a generation ago. So we're here to talk with some folks who are working on this, who are trying to fix this issue, and try to figure out what we can do about it. So first I wanted to start with you, Dr. Stanton. You have an interesting backstory in that you worked in Bangladesh kind of many years ago, and I was wondering, what did you learn there? How do you apply that to your work today?
What a great question. And it is become actually the thread that has gone through my whole career. When I went to Bangladesh, it was a young country. It had just suffered a major typhoon. The rural areas were devastated, and so there were huge migrations up to the urban areas, including Dhaka, where I lived. And I was teaching the communities how to use oral rehydration solution. And the women I was working with had zero education, not even first grade, zero. And so after working with them for a couple of months, a group of them came to me and said, "Why are you just teaching us how to treat diarrhea? Why aren't you teaching us how to prevent diarrhea?" And I thought, all my years of education, and I didn't think of doing that. So I then looked to see, okay, what do we do? What do we know that's really easy to prevent diarrhea? And the laundry lists were not evidence-based and went on and on. Wash your hands, don't let flies get to the food, wash your kids' hands, on and on and on. And so I brought this list in the next day, and we went over it, and all of them kept coming back to needing water to wash your hands, to wash the kids, to wash everything. And eventually one of the women turned to me and said, "But we stand in line for 30 minutes to 2 hours every day after walking half a mile to the pipeline, the pipe stand. We can't possibly use that much water." So I thought, she's right. But then someone else observed, and yet we know some of our neighbors have really low rates of diarrhea. Others have very high rates. Can't we do some sort of a study to figure out what they're doing differently in this community? And I thought, wow, not even first grade, and she's describing a case control study. So that's what we did. We eventually did a major case control study, followed by an intervention based on the findings from that, a longitudinal study, and we significantly began to change the rates of diarrhea with the simple maneuver. And so wherever I have been, I came back to Baltimore, I was in West Virginia, I've done a lot of work in other settings, I realized you don't even begin thinking about treating a population until you have spent time working with that population. And you let them feed into everything that you're thinking of doing in medical care, because time after time, they'll be so much smarter about this than you could have been.
Yeah, absolutely. Well, and we recently got kind of a hint of this issue that women of color face with pregnancy and postpartum care with Serena Williams, actually, who had a pulmonary embolism, and she had to famously wear the cat suit, playing tennis instead of the standard tennis whites, and it caused a big brouhaha. I was wondering if we could, just so we all kind of understand, what are some of the factors that go into these high rates of maternal mortality and the pregnancy complications among women of color? And anyone can answer.
Yeah, I can start. So right now in the U.S., we have the worst rates of maternal mortality of any developed country in the world. And that makes the U.S. the most dangerous developed country in which to deliver a baby and to have a baby. And of course, the rates we know are far worse for women of color, especially for African American women. So there's 700 women that die as a result of childbirth every year in the U.S. But there are 50,000 women who become who suffer from severe morbidity. So they're what we call near misses. They are so severely ill as a result of childbirth that they almost die. So the issue is actually far, far greater than even just the number of women who die, although 700 women who die as a result of childbirth in 2018 is appalling. And our rates have doubled over the past 25 years. So what we know is that about 60% of these cases are avoidable. 60% of the cases are cases that should be and can be treated in the hospital or by a healthcare provider. We also know that for women of color, as you mentioned, irrespective of income and education, that Black women are far more likely to die as a result of childbirth or become severely ill as a result of childbirth. And what we also know is that that often is because of chronic diseases that those women suffer from, diabetes or hypertension or other chronic diseases, also cardiovascular diseases. But there are a range of other issues as well, things like embolism and pulmonary embolism and sepsis and infection, a whole range of other things. And of course, the last thing is that we know with the rates of substance abuse, substance use disorder in this country, we know that more and more women are suffering also from mental illness and are not getting the help they need in terms of dealing with addiction and other kinds of challenges as well. So we have a big challenge on our hands. The fact that we're looking at this issue now is great, but there are some solutions we can start to put in place today and then ones that we need to work on as we move forward.
So I would just like to add that, part of what Stacey's talking about is also sort of as a healthcare system. I run a community health center, a federally qualified health center, that we need to continue to be held accountable, right? As community health centers, as physicians, private practice, and making sure that we are really answering to the needs of women when they need care. Statistically, we know, probably in this room, if you are trying to get prenatal care, it probably will take you 2 to 3 months to get your first visit. If you are trying to get a family planning visit to prevent that pregnancy, it will probably take you much longer. If you're just trying to get your doctor, it's going to take you much longer. So just for chronic disease. So I think that we need to really be conscious and be loud and be held the medical organizations accountable to us as individuals, to make sure that we're meeting the needs. And then once we walk in that door, we need to make sure that we are accountable to that individual, that we are actually introducing them not just to the care, but also to the community so that they can have the resources, as has been said all morning long, about dealing with the determinants of health. Because many of the issues that we're talking about really are the issues of poverty. And if we're not dealing with those, we're not ever going to deal with it. But we also talked about medical records. And medical records, we're so sophisticated, and yet we're not communicating. Our records are not accessible. And so chronic diseases get missed. Sometimes we're not even following up because people are not telling us the urgency of our chronic disease. Oh, you have prediabetes. Here's a diet. Take care of it. That's it. But that is like a predetermined factor for when you get pregnant. That is probably going to be the one that's going to be harmful to you.
I'd just like to add one thing. I agree with everything that was said, and I think that, once again, we have a situation where poverty is so important as a determinant. But one of the really troubling things about this, as we all know, but we have to remember, is that this is a problem that goes across all educational and socioeconomic classes. So there was a very famous paper back in the early 1990s in the New England Journal of Medicine that realized that if you looked at the death rates of college-educated African-American women in childbirth, they were comparable to those of 8th grade Caucasian women. And so this suggests that what we might be seeing are perhaps epigenetic effects, that we might...
Really quick, what are epigenetic effects?
Oh, I'm sorry. These are effects on the changing of the gene over time by environmental influences, so that gene is turned on or turned off in a certain way. By things that means that something that was impacting your grandmother could still be having some effect on you. So it's a very complex disorder, and everything we've said is true, but this one's even more complicated.
Yeah, I think that's right. It is complicated, and I just want to say that's absolutely, I agree with you, and but I think that we still need to make sure that we don't use that as an excuse not to do some low-hanging stuff that needs to be done.
Absolutely.
Well, I wanted to ask about, so a major problem that the Atlantic has actually looked in with a video is maternity deserts. So it's this idea that it's actually, in parts of the country, it just takes a really long bus ride or a really long trip to even get to your OB-GYN appointment when you're pregnant, which is, you know, a huge problem. Where do these maternity deserts come from? How big of a problem are they?
So I was really inspired, actually, when the Atlantic did a story about maternity care deserts here in D.C. Because I think one of the things that has been well documented are the lack of obstetric services in rural areas, the closing of hospitals, and we know that, and it's significant and it's real. The fact that we're also looking at maternity care deserts in urban areas, highly populated areas where there are presumably sufficient numbers of resources or amount of resources to serve women in an area, and women still don't have access to care. So here in D.C., Ward 7 and 8 east of the river, there's no hospital. And the story in the Atlantic talked about a woman that has to go and travel without transportation, has to go all the way to Washington Hospital Center just for prenatal visits. If she has a high-risk pregnancy, she's in big trouble. If she's trying to get to deliver and has to get there in an emergency situation west of the river when she's ready to deliver. And then if she's having a premature birth, that's even more of a challenge. So we started, the March of Dimes, we started to look into this and do even more research to sort of identify maternity care deserts, and we're finalizing that report. It actually will be coming out next week. But what we're seeing is that there are millions and millions of women in this country who live in a county where there is no hospital that offers obstetric services, where there is no OBGYN, women that do not also have health insurance, women that are, when they choose to become pregnant, hopefully they have an ability to choose and make that choice, will then find themselves in a county, in a place where they have to travel, you know, maybe hours, and it may be impossible for them to access the kind of services they need. Mm-hmm. So when we're talking about systemic challenges with respect to not only healthy moms, but healthy babies, we have huge gaps in this system. And we know that those systems are everywhere in this country, and not just in rural areas, although that's a huge issue, in urban areas as well. And I think it's something we have to address by looking at the levels of care that need to be available, but also just the availability of care. It's one of the reasons why we've also been looking very deeply at how we expand the kinds of services where women might be able to access those services and have healthier pregnancies, be healthier before pregnancy, which is really a very important way in which to ensure that they are healthy as well as their babies. But looking at health clinics, at doulas, at midwives, we know that women of color are far more predisposed to wanting to access those kinds of services, but they're also not as available and need to be ramped up as well. So we need full-on solutions to this. This is not just a one-size-fits-all problem. There's no one single solution to it. We have to have a very comprehensive approach, but we actually do have documented evidence of huge gaps in the system that are affecting millions of women.
So we have, again, here in the city, we have a very low-hanging fruit. There's funding for a hospital, and we're talking now about a hospital that's not going to be built till 2023. So why is it taking us so long to build that hospital in an area that needs it desperately? So I think 2023 is 5 years from now. We build things in 18 months, 19, 2 years at most.
Arenas.
Arenas and all kinds of things. But and so that needs to be a priority. The money's there, the land is there, everything is ready to go. And, you know, really the old-fashioned midwife home visiting as a strategy, we now have telemedicine, care coordination, are just places that we can come together with community health centers that actually are funded to do this work. And we should be working much more collaboratively with hospitals to make sure that hospitals are not creating things that are already in the community. We have 2 community health centers in Southeast, and it's taken all these years with the hospitals takeovers of the hospital that used to be there or still there, and no collaboration between primary care and the tertiary care. So,
can I mention one other thing, which is the DC, this is a national conversation. I'm just going to use another DC example, though, since we're here. The DC Primary Care Association issued a fantastic report that actually talked to real women. You know, we, as experts in the field, we love to hear ourselves talk. It's actually good to go out and listen to real women talk about their own experiences. We actually learn and implement things that actually respond to those needs. I think this report was really telling because one of the things that it showed is that then the listening that they did were women who were covered by Medicaid, women that were pregnant, had a baby recently, And what it said was really important. I think one of the things that it talked about was the fact that the word of mouth that is shared among women in communities is as powerful a place to get information as any other place. So if you have a friend or another woman in your neighborhood or your community that went to a healthcare provider and got terrible service, felt disrespected, didn't feel listened to, didn't feel like the healthcare provider was empathetic, maybe something went wrong in her treatment, that word spreads like wildfire, and that is as powerful a place to find, what the community feels about it. So even if there are providers and institutions and places, that is not, the bricks and mortar alone are not enough. Right. They have to be institutions and individuals who are responsive to the community, who listen to women. When women tell them what's going on with them, that they respond to those needs. In too many cases, we're finding, and again, irrespective of income and race. So while this is there are a lot of issues around poverty for sure, an educated black woman like myself can go into a place and be as unlistened to as any other woman, as an African American woman. And so I think one of the things we have to be clear about is the fact that we are experiencing in too many places where women of color just simply do not get the same kind of treatment.
Oh, yeah. Mm-hmm.
And that has been well documented, and
yep.
That's another thing that we have to address and be very clear and upfront about.
Yeah, absolutely. Or people just saying, you need to lose weight, or,
yes.
something like seeing that as
yes.
the solution. I'm going to turn to audience questions in a minute, so be thinking of your questions. But first, I want to dig in a little bit into the solutions to this. Can you guys talk about some of the more promising things you've seen? I heard about centering pregnancy. Maybe you guys could talk a little bit about those types of initiatives.
Yeah, so centering is one strategy, right? So it's not like the all solution, but being able to get women together in a group in the same trimester of pregnancy to talk and learn from each other. Where the midwife really does the minimal amount of work, but the work is really the conversations, the networking that happens between the women is very, very, very important. And we've taken that, and many of us have taken that and said, can we have those same conversations before people get pregnant? So when they have chronic diabetes, or pre-diabetes, when they have heart disease, and when they have any kind of chronic disease, to have that kind of conversation with women to learn from each other. You'd be interesting to know, some of the immigrant women are learning from the Afro-American women and vice versa, and learning about the systems and learning, you assume that you know what the system is because you lived and you were raised in this city for years and years and years and generations. The fact is that there are so many services that our community still does not know, and so we need a bank for those. But centering is one. The other one is around home visiting. Again, these are strategies. Home visiting is not for everyone, but it is for those women and families that are under so much stress that can't really make it to the other side of town to get the prenatal care. There is telemedicine. Telemedicine is another, and care coordination, making sure that we navigate people through the system. How many of you have tried to navigate the healthcare system when you have a chronic disease or when you're even just pregnant to try to, and you're high risk? So navigating that in building a community around them, like you said, of people that they can go to, not only in their neighborhood, but in the place where they work. The work, I just want to say to everybody here, work is a very, very special place for pregnant women. Not just, we've kind of gone the battle of making sure that people can breastfeed in their places of work, but also being able to be accessible and to be supportive of women that are pregnant. It's very, very important, and I'm still shocked of how many people, especially our low-resource individuals, who if they miss an appointment, or come to an appointment and miss a day of work, they are let go of their jobs.
Yeah.
And
I'd just like to pick up on one thing that we've all mentioned a couple times, but that is the power of telemedicine. And if we aren't careful as united sort of professions, telemedicine can once again be designed so that it's in the province of the wealthy. And it makes our lives very much more convenient. Telemedicine is something that the poorest of the poor around the world can adapt and they can use it to just jump miles beyond where they would be. But it requires attention, it requires focus, and it requires money that is looking at their needs that can be addressed by this, and not just taking care of the needs of the better off.
A few quick solutions.
Yeah.
There's legislation pending right now in Congress that would authorize maternal mortality review committees across all states. We do CDC does a great job of collecting data on pregnancy-related deaths right now, but we don't have enough information to actually delve deeply into the actual causes of those deaths so that we can understand, collect better data, and design interventions at a local level so that we can actually reduce deaths. The other thing I would say is that in addition to supportive pregnancy or centering pregnancy, group prenatal care, which we know is an evidence-based program which can reduce the risk of preterm birth by up to 40% in women of color, up to 30% for all women. We know that there are programs that are just not simply available to many women that can be scaled. The last thing I'll just say is that I think there is an important part of this conversation that does start with medical schools, and it's how we train our medical providers. And again, these are not the only participants in the healthcare system, but I do think we should be partnering with medical schools to make sure there is the right kind of training, empathetic training, and training to make sure not only that doctors, physicians recognize social determinants and understand the connections and community that can help alleviate some of those things, but even understand the different ways, different nuances of dealing with different patients across. The gentleman that talked before about the code switching and the different languages, I thought was really amazing, because I thought what he was really saying is we are learning how to relate and communicate with different audiences in ways that they feel heard and respected, and I thought that was a really great comment at the end of the previous section.
I would just say also that we talk a lot in this panel about the primary care and about community. We also want to make sure that there's some guidelines and protocols for hospitals, so that when women arrive, that the hospitals are ready for a hemorrhaging cart that there's nearby, that there's accessible blood transfusion if a woman needs it. Sometimes, and this is honest to God because I've been there in some of these hospitals, if depending on what kind of insurance you have is the way that people get treated. And so I think we all need to be held accountable with the whole healthcare system, because those few moments of not being able to get that blood on time and not having that card can mean life or death for a woman.
Yeah. Well, unfortunately, that's our time. But thank you guys so much for coming and digging into this important issue. And thank you all for being here. Thanks.